Ashley, can you come and sit? Because I want to do some quick introductions. And what I really want to do is in the interest of trying to create a little more teamwork, I thought we'd go around the room and have everybody introduce each other. We've got the community health team, or part of it anyway, from Blackstone here. And they're people you might run into from time to time. They're amazing. And I wanted them to be able to meet the folks in Central Falls EMS who are also amazing. So why don't we start with Ashley and go around the room.
Ashley Valerio, community health worker, part of the community health team in Blackstone, and overdose outreach coordinator for the city.
She's the person who goes out and knocks on doors of people who've overdosed.
We go together.
Stephanie Blackstone, community health team, Esther Streeter.
Sylvia Dames, part of the community health team at Blackstone.
Scott Hewitt, community health team at Blackstone. Jack House, Central Falls Fire.
Ken Gamache, Central Falls Fire.
That's Chief Gamache.
Hey, how about that?
Sean Goggin.
The ghost. Ross Blanco.
Mark Landry.
Scott Badillo. Brian Bradley.
Andres Nunez.
Keith Williams.
Paul Chalmers.
Rick Haskins.
Justin Carino.
Musa Milano.
Kevin Gante.
Kevin Battersby.
Lou Forts.
Beck.
Carlos Blanco.
Arthur Perry.
Charles Vanderford.
Ryan Griffin. Jared Bennett.
John Carvey.
Debbie Navarro.
All right, we got everybody. Now let's see if I can sort of blunder my way through this talk with the recognition that I saw it for the first time 10 minutes ago. So let's see how we go. The good news is I do this all day long, so I have a little of exposure and experience with it. So first, can I do the slides, or are they not working? I'll try it. Hang on. So can somebody give me the first slide? Thank you, sir. So we're going to talk about behavioral health at Blackstone, talk a little bit about anxiety, major depression, bipolar disorder, and schizophrenia, and talk a little bit about red flags. I'm not going to do the case studies because I didn't really prepare them well enough. But I think I can get us through the didactic stuff. Next slide. Next slide. So generalized anxiety is probably what I see more than anything else. It's excessive worry occurring more days than not for 6 months, difficulty controlling worry, restlessness, easy fatigability, difficulty concentrating. People say their minds go blank, irritability, muscle tension, sleep disturbance, marked impairment in social, occupational, and other important areas of functioning. And you also see lots of, I'm missing the word. When somebody is breathing real fast and can't quit. Hyperventilation, thank you. Hyperventilation is almost always an anxiety disorder until proven otherwise. Next slide. Major depression. I guess we're going to get to the definition on the next slide after this, but it's worth knowing that the possibility of suicide exists in all major depressive episodes. It can be mild, moderate, or severe, and can occur with what she calls mood congruent or mood incongruent psychotic features. So psychosis is a thought disorder where people's thinking is or appears unconnected to the reality that they're presented with. And so when she says mood incongruent or mood incongruent psychotic features, when somebody is obviously psychotic, they can say, act, believe things that are related to what their overall mood is. So, they can sound depressed or they can sound completely undepressed. The challenge is to assess whether they have a thought disorder or not, whether they're actually connected to what's happening around them. Next slide, please. So the definition of major depression is a change in previous function and at least 5 of the below symptoms lasting for 2 weeks. They have to last 2 whole weeks. And those include depressed mood, lack of interest or pleasure, significant weight loss or weight gain, insomnia or hypersomnia, that's sleeping too much or not sleeping at all, fatigue, feelings of worthlessness, diminished ability to think or concentrate, and recurrent thoughts of death. In the real world, it's the insomnia that to me is the major marker of a significant depression. And there is some relationship, which I can't say I understand, between sleep and mood. So that if you are not sleeping, your mood tends to go into the toilet. And the way, when I'm taking care of people, the first thing I work on is getting them to sleep, because once you can get them to sleep through the night, then their mood improves. Next slide, please. Major depression in primary care is something we see quite frequently. We screen using these little sets of questions. So everybody who walks through Blackstone gets a couple of questions to assess whether they're depressed or not. If we identify depression, we assess the severity and rule out other conditions. There are medical problems that can show up and look like depression. The most significant is probably hypothyroidism. And then we provide treatment, psychotherapy, using something called CBT or cognitive behavioral therapy that helps people identify inappropriate or unhelpful thoughts and sort of learn to push them out of the way. We also provide medication and encourage exercise, and that takes a team of people, because our behavioral health people, who are mostly social work trained, can't prescribe medication. So it's teamwork between the medical clinician and the behavioral health clinician. We've actually worked out an integrated mental behavioral health process that's, I think, reasonably effective. That means that when I run into somebody who I think is depressed or has significant general anxiety, I walk out of the room, go and get one of the behavioral health people, bring them into the room, and we do what's called a warm handoff. I sort of say to the patient, this is my expert on treating depression. I want you to work together for 6 weeks and report back to me. And that works pretty well, getting people set up in treatment. Around the world, when primary care folks deal with depression, it used to be a big problem that when you identified somebody with depression and said, well, go and see a therapist, 40% of them would go and 60% of them wouldn't, and say, so they didn't recover so well. But now that we've got everybody working together, things actually work work way better than they used to. We refer to a higher level of care if needed. That means, if somebody's got depression and isn't responding to medication, we will sometimes refer to a psychiatrist and ask the psychiatrist to think through both the diagnosis and the treatment. There are other modalities available to psychiatrists that aren't available to us, including ECT or electroconvulsive shock therapy. But for depression, the need for referral is actually relatively small. Getting access to psychiatry is still a major problem in this state, as most psychiatrists, or too many psychiatrists in Rhode Island, don't take any insurance at all, and there just aren't enough psychiatrists to see people who only have insurance. It sounds a little weird, but only have insurance is the way psychiatrists think about it. And it's a particular problem for people with Medicare. That is everybody over 65. Because as far as I know, there's almost no psychiatrist in Rhode Island who takes Medicare, which really limits access to psychiatry for people over 65, which is why all people over 65 are crazy. I'm kidding. Go ahead.
Why is that? Like, why don't they accept insurances?
Because cash is king.
You figure they'd get money if they went through insurance. And is it the,
So actually, it's because there are few enough psychiatrists that they don't need the insurance. There are enough people who are willing to pay them out of pocket. And going through the insurance, billing insurance, particularly if you're in a small private practice, is hell. There are at least 5 major insurers, but they're probably, when you get right down to it, 40 different insurers, and they all have their own billing process. They all pay for different stuff. It's a huge headache, and that's one of the things that creates chaos in what some people call the healthcare system, and I call the healthcare market, because I don't think we really have a system. I think we just sell stuff and hope for the best. But the insurance system, we have an insurance system, but boy, is it a pain in the neck to deal with if you are on the provider side. And I've worked with your billing company, and I have a feel for that the folks who bill for you, have just as much of a hassle. And my guess is you get some bounce back from time to time of your billing company asking you for more information or information this way or that way to get the city paid, because you gotta jump through all sorts of hoops for any provider of a medical service to get paid when you're trying to deal with these crazy insurance companies. Not that I have feelings about that either. Anyway, I'm going to skip the case study, so next slide. Bipolar disorder is actually something we've described best in the last 15 or 20 years. When I started in practice, bipolar disorder was almost unknown and not thought of as fairly significant. And what we would find would be about 10% of people who we thought were depressed would not respond to antidepressants. In fact, about 10% of those people would actually get worse. And that let some of us begin to understand that there were, what looked like depression probably were 2 different diseases. One is depression as I described it, and one is the depressed part of bipolar depression. The depressed part of bipolar disorder. There are 2 kinds of bipolar disorder. Bipolar 1, which is just mania, just people, and I'll describe that in a couple of minutes, just people getting incredibly hyper. And then there's bipolar 2, which is hypomania and depressive episodes. Those are people who cycle from being, high as a kite and thinking that they can, sort of go and control the world, and they're full of energy and they think everything positive is happening, and they're gonna, climb tall buildings with a single bound, or fly over tall buildings with a single bound. And then they go into these periods of what look like depression, where the world feels like it's ending to them. The one I remember most is one of a guy who I saw when I was in medical school and doing a clerkship in a psychiatric hospital, who every Christmas time he would get manic, and he would go into the store and buy hundreds of poinsettias and send them to like everybody in the city. And then he would crash and burn a little bit after that. The lifetime risk of suicide for people with bipolar disorder is 15 times higher than the general population, and people who are both manic and in the depressed episodes are at risk for suicide. Bipolar can be either mild, moderate, or severe, and can also occur, if it gets psychotic, which it sometimes does. That means, when there's a thought disorder, when people lose the connection to the world around them and lose a rational explanation of things going on around them. Those psychotic episodes can be, can match their mood, or can be different from their mood. Once you lose that connection to the world as it is, basically anything can happen. Next slide. So the further definition is, the definition of the manic episode is a distinct period of abnormally and persistently elevated, expansive or irritable mood, along with abnormally increased I think increased goal-directed activity or energy, lasting nearly every day for 1 week. And it occurs with 3 or more of the following: grandiosity, decreased need for sleep, pressured speech, flight of ideas, distractibility, excessive involvement in high potential for painful consequences situations. So people who are just out there, climbing over buildings because it's Tuesday, they may well be manic. People who are doing things that just don't make sense, but would be considered by most of us impossible. Those are people who are probably in a manic episode. Bipolar 2 has similar symptoms on the manic side, but the definition of that is that one needs to last only for 3 to 4 days and may not actually interfere with functioning. And they have more depressive episodes. You will run into these people in your regular life. There's kind of a continuity and there's probably more bipolar disorder out there than you think. These are the people who, from time to time, get so that you can't shut them up or get them to sit down. They just start climbing the walls with all their incredible energy.
I'm having a manic episode right now.
Well, and once you begin to recognize it, you start to see it in some people. It's not uncommon. It actually provides sometimes some energy and some entertainment, because often these are engaging and pretty exciting people. It's when they go into a depressed episode, then things get a little more difficult for them. But the people who you'll see are people at one end of the spectrum, one end of a bell-shaped curve. There are many, many people who live with these disorders and have them as challenges to their daily life more than as things that cause them to need hospitalization. Next slide, please. In primary care, we assess the severity and rule out other conditions. And I don't know what Kelsey means by MDD, but I think she must mean major depressive disorder. I got it. I got the code. Because there is this confusion between depression and bipolar disorder. We have a number of medicines that are quite effective for bipolar disorder. Sometimes we use psychotherapy, though psychotherapy is more helpful around supporting people who are struggling with the disorder, helping them figure out how to cope in their daily lives, than it is to help people treat the disorder itself. And then we also often will sometimes refer people to psychiatry if we need to, understanding the difficulty of getting access to psychiatry. Just parenthetically, we have been trying for about 2 years to hire a psychiatrist to be part of Blackstone, and I'm hoping we will get that done in the next few months, because if we had somebody internal, then we wouldn't have to refer anybody. I think there's a reasonable chance we'll get that done. Next, schizophrenia. Formally defined, 2 or more of the following, each present for a significant portion of time during a 1-month period: delusions, hallucinations, disordered speech, grossly disorganized or catatonic behavior, negative symptoms, diminished emotional response, diminished emotional expression. I don't know what abolition is, but and also evidence of a significant impairment in major areas such as work, interpersonal relations, and self-care. The guy who's walking around talking about the devil walking through the windows, or that they're hearing a speaker telling them to do things. That's somebody who's in the middle of a schizophrenic episode. And the danger of schizophrenia is that their thinking is so disordered, they can't understand how to take care of or protect themselves or others.
Can we bring those to you?
Absolutely not. That's way beyond what we're capable of doing. So They need, psychiatric hospitalization, they need medication and stabilization. And many people with schizophrenia, once stabilized, do well. But when they're in the middle of a schizophrenic episode, it is a very difficult thing. And you really need a hospital and hospital level of care to take care of. So that's psychiatric hospitalization, not general hospital. Most schizophrenia develops in adolescence. So that typical person is somebody who's, had a pretty regular life and then hit 17 or 18, and then all of a sudden it goes totally off the wall. And that's often schizophrenia itself. I've seen it relatively rarely, but when I see it, it's pretty damn challenging. The person and the person's family, you don't know where it comes from. It seems to come from no place, and things get completely out of control. And those people, they need as much support as we can give them, but boy is it hard to get them into shape. Next slide, please. Suicide risk is quite significant. About 5 to 6 of people with schizophrenia die by suicide. 20% attempt suicide on one or more occasions, and many have significant suicidal ideations. You can sometimes see suicide with catatonia. That is where people will just sit there and not react. Sometimes they won't get out of bed. Sometimes they won't feed themselves. They are just, their eyes are open, but nobody's home. And the severity is determined by the assessment of symptoms. It's, the severity of schizophrenia is really whether somebody's functioning or not. And we put a lot of time and energy into helping people with schizophrenia function. One of the things that not many people know is that people with chronic mental behavioral health disorders like schizophrenia and severe bipolar disorder and even severe depression have a life expectancy that's 25 years less than the average because they just can't figure out how to take care of themselves. So these folks often die in their 40s and 50s if they haven't died of suicide along the way. There's a huge incidence of diabetes associated with this disorder because both obesity and diabetes is often caused by the drugs we use to treat them. The drugs we use to treat them have other significant side effects. This is not a disease you want, specifically schizophrenia. This is just not a disease you want if you can avoid it. It is not a fun situation. Next, in primary care, this is just about when we recognize it, we refer it. It is way out of our league to start treatment. The drugs used in the treatment of schizophrenia are very specific. Most of us don't have very much experience prescribing them. And some of us get to the point where we get comfortable managing them over time. So that somebody who's schizophrenic and is on one of the major tranquilizers or what are called atypical antipsychotics, those get started in the hospital and maintained initially by a psychiatrist, and then they refer them back to the primary care practice, and then we check in with the person every once in a while, every 2 or 3 months to see how they're doing, refill the medicine as long as the person is functioning. But for most of us, if somebody starts getting out of control, the first thing we do is send them back to psychiatry for medication tune-up. We generally don't manage this stuff ourselves because it's just a little too specialized for us. In most of our practices, we'll have 1 or 2 people with fairly severe chronic schizophrenia, but very few primary care folks take care of 50 or 100. That's a much more specialized practice. They use, as I said, the mainstay of treatment is medication. Behavioral therapy is sometimes used to support people to help them figure out how to live their lives, but it's not the mainstay of what we do. Next slide. So red flags. What are things that would say go to the hospital under any circumstances? The first is an altered mind state. that is being not oriented, being delusional, or being or having auditory or visual hallucinations. That kind of stuff means people aren't safe to take care of themselves because they just are not in control of their own senses or their own choices. And one of the first things I do when I walk into a room of anybody who's got a mental or emotional issue is I assess what's called their ego function. I'm asking myself the question, is this person able to make good choices for themselves? Is the human being present enough to sort out what they want for themselves? And that helps me understand whether they're safe, because if that ego function, that ability to protect oneself isn't there, then all bets are off and they need to be in the hospital. That happens, thankfully, pretty rarely, but it's the thing I look for when I walk through the door. The next red flag is the expression of an imminent risk to self or others. I'm going to kill myself, I want to kill you, I want to kill somebody. We take those threats extremely seriously, and all those people need sometimes hospitalization and sometimes involuntary commitment. And yes, we can do that in the primary care situation if we need to, but we do it also quite rarely. Thank goodness. And the other red flags, the other red flag that Kelsey mentioned is people who are frequent users. When somebody's coming back and back and back seeking EMS or medical care, they're telling us something about their own inability to control their lives, and that suggests an underlying mental behavioral health problem. Those are the people we often will present at the multidisciplinary team, which happens here every Friday at 1:15. Because you often need a kind of bunch of people around the table trying to figure out how to take care of them, because they will, there are a bunch of people who will go from place to place, sort of tell a different story to different clinicians, and you kind of got to get everybody around the table to figure out, what's really going on with this person and what the truth is. We've been able to do that quite successfully, but when you're seeing somebody over and over again, it's time to think about, some underlying mental behavioral health or substance use issue. Next slide, I think that might be the last one. Oh, I'm going to skip the case study. Yes. And then a question that just might show up on the examination, just saying, is when treating a behavioral health condition, it is important to assess for safety, as many diagnoses increase the risk of suicide. True or false? Cool. And behavioral primary care is not equipped to treat depression. False. Cool. All right, I think we are through the teaching part of this week. And again, forgive me for not being Kelsey. She's much nicer than me and some other things as well. So we're actually coming to the end of what we're doing together. We have a opportunity to show us what you've learned. Deb's going to pass out the little examination, though examination is probably too wrongly put. It's not meant to trip you out. It's just meant to sort of record that you were here. And what we're going to do is ask you to fill it out. When you're done filling, please try to answer every question, even if you're not sure of the answer. It gives us a little bit of feedback about how effectively we communicated. And once you finish this, you're done for the week. Did I mention before that Jason Rhodes just texted me and said he can't come? So he's not going to be here, but what we're going to do is once we've gotten and marked up the examinations, we have certificates for you, which Jared's going to sign, I'm going to sign, and Jason's going to sign. We're going to get them over to Jason. He'll get them signed this afternoon, and then we're going to bring them to Jared and he'll distribute it. So that really concludes the formal part of the presentation. Thank you all for being here. Thank you all for the work you do every single day and night and weekend. Thanks.
Thank you.